Okay. While people are getting settled, my name is Alta Charo. I'm from the University of Wisconsin, and we're going to move on now to the first of two sessions that are going to focus on potential risks of gain of function research. So we're going to be focusing first on biosafety, and the next panel is going to focus on biosecurity. We have four panelists, again about 10 minutes each, and then time for discussion. And we've already begun receiving questions from the web. So I look forward to a good discussion. Our first speaker is going to be Barbara Johnson.
Thank you. I've been asked to discuss an overview of biosafety conditions and practices in advanced, emerging, and developing nations because for about the past 15 years, I spend 25 to 30% of my time in labs in emerging and developing nations. So the first few slides that I want to go through highlight some of the challenges, not just here, but also in other countries. Incomplete inactivation, whether it's due to procedural error, deviation in procedures, or inappropriate decontamination processes or decontamination agents, is not a problem that's unique in the U.S., and you'll see just a couple of brief examples in other countries. And it has resulted in laboratory-acquired infections or illnesses, which I'll refer to as LAI, and in some cases, these resulted in community spread and deaths. So these are just a few examples that I've pulled out of the available references on SARS. Again, human errors or mishaps have at times caused laboratory-acquired illnesses. The WHO Western Pacific Regional Office investigated these and other incidents which occurred in Singapore and other areas. And in the course of their investigation, what they found was there were problems with laboratory management, lack of biosafety policy, biosafety procedures, training, PPE, supervision of less experienced lab personnel, the need for an accountable occupational health and safety organization or program in each laboratory, and also there's a need for quality control and assurance. So what the WHO recommended was the development of legislation of national biosafety standards, procedures for timely reporting and follow-up of accidents, worker health monitoring and countermeasures, accreditation or certification of biosafety level 3 labs, inventory of infectious agents. And so for what I've seen, even in the last 5 years, which are after the WHO recommendations, there have been many improvements made, mostly in our emerging and our advanced nations. A lot of our developing nations are still working on this, but there is serious consideration being given to those recommendations. These are just a few of over 200 reports of laboratory-acquired infections from the Belgian Biosafety Listserv. I focus mainly on those related to transmission errors and aerosol transmission, as this is the main concern with MERS, SARS, and influenza infection. Infection via the inhalation route is often not recognized at the time of exposure. There's no definitive eureka moment. It's not a needle stick, it's not an animal bite. It's not dropping a pipette. These are very difficult to diagnose, and well, they're difficult to recognize at the time of exposure, and it's estimated that only 20% are actually recognized. So interestingly, or very sadly, many countries that were many countries have basically said in reports, we've never had a laboratory-acquired infection. And these are countries that have operated containment labs for in excess of 20 to 30 years. This information came out in another National Academy of Sciences publication on a conference that basically looked at high containment labs, and this was done in Turkey just a few years ago. So I question how anyone could really say we've never ever had a laboratory-acquired infection. I think what they mean to say is we've never been able to account for it, we've never investigated it, or it's never been reported. Some countries and entities within countries have more robust inventory and accountability than others. So the question this slide brings to bear is, how do we better safeguard our samples against having residues in the permafrost, whether this is going to be gain of function or other types of research? Because there will be materials that are left in freezers. Whether this is accountable in all countries is up for grabs. And this is something that I think we have to grapple with when we have this discussion. So I mentioned the WHO findings and recommendations earlier, and that doesn't mean to say that we haven't had findings ourselves here in the US. And you've all probably read the reports. These are all publicly available on what the findings and what the responses were by both the CDC, the NIH, and then the White House memorandum that requires enhancements for biosafety or urges and biosecurity in the US. We talked a little bit about types of oversight we have. The US has a layered approach to oversight for select agents, for recombinant DNA, for biosafety, biosecurity, and biocontainment. It's of note that over the past 30 years, no material has been released into the community and caused an infection by accident, and no LAI in the research lab has resulted in community illness either. We've also noted that, that SARS is covered, HPAI is covered, 1918 influenza is covered under the select agent regulations, but MERS is not covered. So some global observations. Everybody here knows that you've seen the GAO reports that over the past few years we've had what we call this proliferation of biosafety level 3 labs. We're not alone. The number of BSL-3 labs overseas has proliferated at the same rate. Now the good news is the number of biosafety associations globally is about 30 now, and they've more than doubled since 2009, which was a doubling since 2005. So they are witting of the need for biosafety and biosecurity. Many countries have national biosafety standards, the US, the UK, Canada, Australia, New Zealand, Singapore, China, and the list goes on. However, others do not yet have codified standards. They do, however, predominantly use either the US BMBL or the WHO standards or the UK HSE guidelines. Few, however, have independent oversight organizations. So in the previous slide, we looked at some of the oversight organizations. And some are just very recently established as national biosafety committees. And they struggle to find expertise and also to find volunteers. Most focus only on genetically modified materials. They don't focus on pathogens of interest that we're talking about today. Sustainability, operations and maintenance, cost, these are very real concerns even in the emerging countries and some advanced countries. Many labs in the developing and emerging countries barely meet BSL-2 standards in terms of either their infrastructure, their training, their PPE, and their supplies. And this is a reality that they deal with. Culture is incremental, and it's hard to develop. Many senior scientists don't embrace changes that quickly, meaning biosafety changes, requirements for reporting illnesses. Groups conducting oversight should not have a vested interest in allowing or stopping work, and we need better risk assessments with the ability to consider what I call the what-ifs and the possible unknowns. Does every locality, even here in the US, have the ability to respond if a laboratory-acquired illness becomes community spread? So think of the SARS experience in Hong Kong and Singapore, and then think of the US Ebola Texas experience and the U.S. non-Ebola New Jersey experience. So we probably need to get a little bit better in our responses. It's not common to find leaders at institutions. It's not uncommon, pardon me, to find leadership at institutions discouraging the reporting of laboratory-acquired illnesses and not sharing reports and blaming workers. And this is very common in the emerging and especially in the developing countries. Even in the U.S., it's actually hard to get specifics on all exposures, investigations, and outcomes. And no offense to my esteemed colleague, especially when it comes to select agents. If you've ever seen some of the congressional information that's released, it's about this long, one line, maybe 8 words. And these are lessons learned that we're losing an opportunity with. So it's really time to have a more robust risk assessment procedure, reporting for laboratory-acquired infections, near misses, accidental reporting systems, and it's not just because of gain of function. It's because of all the work that we do.
Thank you. Okay. Next, we'll hear from Rob Wyatt.
Thank you. Thank you very much. I'd like to thank the meeting organizers for inviting me to come and speak. And actually, Dr. Johnson and I had not huddled before my presentation, but I think that some of the questions she asked in her presentation may be answered in mine. I'd like to spend the next few minutes updating the group on the Select Agent Program incident reporting results. I'm responsible for the CDC Division of Select Agents and Toxins, and we're responsible for enforcing the select agent regulations for human pathogens in the United States. And there is a specific section in these regulations, Section 19, that requires reporting of incidents. If there's an incident involving a theft, loss, or release of a select agent or toxin, that's reportable to either CDC or our partners at the Department of Agriculture. So this may be one of the few examples of a formalized reporting system by which incidents are reported to a central location. In our guidance related to select agent theft, loss, release reporting, we encourage reports. We encourage institutions to let us know as soon as possible if they think something may have been amiss. I think in some of the earlier discussions today, we've heard that if oftentimes an exposure may not be overt, and as soon as a response can be mounted, you can reduce the potential of someone becoming sick as a result of this. So what I'd like to share with you is reporting data from the time period of 2005 to 2012. These are reports that were submitted to CDC. I do not have information on reports that were submitted to our partner at the Department of Agriculture. Over that time period, we received a little over 1,000 reports, and about half of those were from entities that are designated as exempt from the select agent regulations. We do not require every diagnostic laboratory in the United States to register for select agent possession. If a laboratory doesn't intend to possess a select agent, but they could encounter one in their routine business, we don't require them to register with us, but they must fulfill the reporting requirement. So about half of the reports that we received over this time period were from these exempt entities. When we looked over the reports, we noted that there were around 3,780 potential worker exposures described in these reports. And throughout the time period, we only had 10 reported laboratory-acquired infections. 5 of these were from registered laboratories and 5 from exempt laboratories. As Dr. Johnson mentioned in her talk, there is no evidence that there's been any transmission of these agents to the public. What we did was we looked at the reports in terms of 3 buckets. One bucket was a report in which there were no potentially exposed workers involved. Another bucket is a report in which a single worker may have been involved, And then the third bucket was an incident in which multiple workers could be involved. And we found that in the no worker involvement events and single worker involvement events, most of these events were reported to us by registered laboratories in the system. However, when we looked at the events that involved multiple workers, the significant majority of those were reported to us by exempt laboratories. Similarly, when you look at the data in terms of potential individuals exposed by these events, for single exposure events, the majority of those were the registered laboratories. However, the great majority of multiple exposure events in terms of individuals exposed were from the exempt laboratories. These next two slides, I'm sorry. Hit the wrong button there. The next two slides break down these events in terms of the type of laboratory in which they occurred. The first slide focuses on registered entities, and the next slide that I'll show you focuses on exempt entities. With respect to the registered entities, most of these incidents, the single exposure incidents, occurred at BSL-3 or animal BSL-3 laboratories. When we looked at multiple exposure events at registered entities, we found that approximately an equal number were reported from BSL-2 and BSL-3 laboratories. However, we saw more exposures per event in a BSL-2 laboratory. There was quite a contrast when we looked at the laboratory types from the exempt entities. The great majority of exposure events, whether they be single exposure or multiple exposure, occurred in BSL-2 laboratories. Now that should not be surprising. BSL-2 is the laboratory standard for most diagnostic work in the United States, and for the vast majority of pathogens that are handled in BSL-2 laboratories, BSL-2 is sufficient. However, if these laboratories encounter a select agent which requires a higher level of containment for worker safety, that could be a problem. We also looked at these reports in terms of the type of activities associated with the event. And in these next two tables, the acronym LOC stands for loss of containment. And what we define there is that it was an activity that was done with insufficient personal protection or insufficient biocontainment equipment with respect to what would be recommended for the agent involved. And when we looked at the registered sector, we found that for single exposure events, needle sharp injuries were the most commonly associated activity with these events. For multiple exposure events in registered entities, we found that the loss of containment condition and a common spill were the activities most likely involved in those reports. When we looked at the reports from exempt entities, we found that the loss of containment condition was by far the most common activity associated with exposures, whether it be in a single exposure event or in a multiple exposure event. We also took a look at the 10 confirmed laboratory-acquired infections that were reported during this time period, and all 10 of these involved either a bacterial or a rickettsial agent. In the registered sector, the majority of these occurred in Biosafety Level 3 laboratories, and as one might expect in the exempt sector, the majority of these occurred in Biosafety Level 2 laboratories. Now, since we've been spending a lot of time today talking about SARS, MERS, and influenza viruses, I thought that I might share with you the data that we have with respect to those particular agents. We don't regulate MERS, so I don't have any MERS data for you. But with respect to SARS, since we began regulating that agent in 2012, we have had 5 reports. 3 of those involve a loss of containment condition, 1 involves an equipment failure, and 1 involves a spill. There were no laboratory-acquired infections associated with any of these events. We've been regulating highly pathogenic avian influenza since the regulations were significantly enhanced in 2003. During this time, we've had 46 reports of incidents associated with those viruses, 45 of which were from BSL-3 or animal BSL-3 laboratories. The activities associated with those incidents include the loss of containment condition, spills, animal bites, and sharps injuries. So in summary, from 2005 through 2012, we received around 1,000 reports of incidents involving select agents at CDC, or CDC received about 1,000 reports of incidents involving select agents. There were 3,780 individuals potentially exposed, of which 81% of those were from exempt entities. The typical type of event that occurred at a registered entity was typically a single exposure type of event, and the typical type of event that occurred at an exempt entity was a multiple exposure event. Bacterial and rickettsial select agents were the most commonly involved in these incidents. The most common laboratory type of incident was BSL-2 at an exempt entity. 77% of our reports described an incident of that type. The most common activity associated with potential exposures was the working outside of containment condition. And when you look at rates, and one of the nice things, we've heard a lot of criticism of the regulations thus far today, but one of the nice things about having a regulatory program is that we do have some denominator data. We know that during the time of our study, approximately 10,000 individuals were approved for access to select agents in the United States. So if one does the math, one finds that in registered laboratories, the annual rate of laboratory-acquired infection for a select agent worker is really quite low. In fact, on the plane coming over here this morning, I took a look at some traffic injury data for the state of Georgia, and I believe if one looks at that data, one could conclude that a select agent worker in the state of Georgia is probably more likely to become injured driving to work than they are to become sick once they get there. Thank you.
Thank you. Rebecca Moritz.
First of all, I would like to thank the Academy for the invitation to speak today. We are grateful for the opportunity to discuss our gain-of-function research decision-making process. I will briefly describe the biosafety and biosecurity review of gain-of-function research conducted at the University of Wisconsin, as well as briefly touch upon some risk mitigation measures we have put in place. Now, select agent research at the University of Wisconsin is considered a privilege, not a right. Any individual that does not meet our biosafety or biosecurity standards is not allowed to conduct research with select agents. In addition, I want to stress that conducting gain-of-function research is not something taken lightly by our institution. So the review of Dr. Koga's research is a process involving multiple groups and levels of oversight. A significant amount of time and resources is spent reviewing his research. The process began before NIAID funded his multiple grant proposals. Now, the grant that addressed the H5N1 transmission work was funded in 2006, and the grant that addressed the 1918-like work was funded in 2008. Now, mind you, both of these grants address questions that were identified by NIAID and WHO as influenza research priorities. Now, our IBC had a thorough discussion of the research before it was funded and determined that the risk mitigation measures were appropriate. I would also like to point out that the discussion did include dual-use research of concern. Now, Dr. Koga consistently revises his biosafety and biosecurity protocols to regularly include new experiments and methodologies. Since the beginning of 2006, his influenza research protocol has been reviewed over 40 different times. Now, following the March 2012 DIRC policy, the university chose to form an IBC subcommittee to review research for DIRC. Recently, this committee was revised to account for the new regulations in the September 2014 DIRC policy. So the DIRC subcommittee is responsible for reviewing grants, experiments, and manuscripts for DIRC. Then that information is then given to the full IBC for a thorough discussion, and then that information is then given to an additional committee. This additional committee, considered a best practice by multiple federal agencies, including the FBI, is called the Biosecurity Task Force. Now, the Biosecurity Task Force, to the best of our knowledge, is a unique committee. It is comprised of key individuals and experts from our campus as well as our state, including our responsible official, alternate responsible officials, biosafety officer, Director of Environmental Health and Safety, and then key representatives from legal, university communications, University Health Services, the Associate Research Deans, University Communications, as well as the State Laboratory of Hygiene, and also, our State Veterinary Diagnostic Laboratory. And I forgot law enforcement. You can never forget law enforcement. The mission of this broad group is to ensure the highest level of safety and security in our select agent laboratories. The Biosecurity Task Force meets monthly and regularly discusses all aspects of Dr. Kuoka's research. The select agent program works very closely with the IBC and the BTF to ensure that the facilities, practices, and procedures in place in Dr. Kuoka's laboratory meet the stringent biosafety and biosecurity standards set by these committees. Now, while the merits of Dr. Kuoka's research are decided by the agencies that choose to fund it, it is imperative of the DIRC subcommittee, the IBC, and the BTF to evaluate the risks to the institution and the public. Importantly, a biosafety or biosecurity failure in Dr. Kuoka's laboratory could jeopardize our institution's $1 billion research enterprise. Each body approved Dr. Kuoka's research based upon risk assessments, looking at best practices, policies, and procedures both nationally at our institution as well as in Dr. Kuoka's laboratory. So this risk assessment also included extensive risk mitigation measures that have been put in place by our institution, as well as what we perceive as a culture of safety consistently put forth by our select agent program. So what risk mitigation measures do we have in place? I'm only going to briefly touch upon the ones that are most relevant to the gain of function debate. So first we start with the facility, the Influenza Research Institute. This is a standalone facility that only houses Dr. Kuoka's research group. Now this point is very critical because it allows us to control all aspects of the facility and all activities inside of it. No one is allowed to enter the building without an appointment unless they are an employee, and no maintenance is allowed to be done on the facility without employee knowledge. Annually, the facility is decontaminated and preventative maintenance is done to ensure that the IRI is functioning optimally. Now, the Influenza Research Institute was specifically designed for all types of influenza research, and it is essentially built like a spaceship with every redundancy possible. Now, Dr. Kuoka's transmission experiments are specifically done inside of a BSL-3 agricultural suite, which is essentially a BSL-4 minus the positive pressure suits and a chemical shower. Basically, BSL-3s are a box within a box that allow for open animal holding. But Dr. Kuoka takes his transmission experiments one step further and uses HEPA-filtered ferret cages for primary containment of the animals. Personnel wear personal protective equipment at all times with working inside the high containment facility, and there are over 75 standard operating procedures for entering, exiting, and conducting research in the laboratory. Any researcher who wants to work in the containment laboratory must undergo extensive hands-on training with a mentor and must pass proficiency testing before they are allowed to work in the containment laboratories. In addition, they must also undergo hands-on laboratory refresher training as well as regular training updates. So when it comes to performing gain-of-function transmission experiments, we've only allowed Dr. Kuoka's most senior research staff to do these experiments, and they're always done in at least pairs. So like every select agent program, we're required to have incident response and security plans for any number of possible events or scenarios that could happen. So Dr. Koga and his researchers participate in hands-on and scenario drills. We are fortunate to have a dedicated trainer to our select agent program who designs and runs these programs. In addition, we have myself, a biocontainment engineer, and a biocontainment control specialist supporting our select agent facilities. So what types of scenarios do we train for? Security threats, natural and human-made disasters, as well as emergencies such as a fire inside of a containment laboratory. Now imagine telling the fire department that they cannot fight a fire. That is exactly what we had to do when we were commissioning the Influenza Research Institute. If there is a fire inside of one of our high containment laboratories, the fire department has the order to let it burn and to just prevent the fire from spreading beyond the perimeter of the containment laboratory. Now imagine telling emergency personnel that they cannot go into an area to attend to an individual with a medical emergency. We routinely conduct drills showing lab personnel how to decontaminate someone and bring him out of the containment facility and then hand them off to emergency personnel. We also run scenarios and live drills for an exposure or potential exposure, or if a researcher exhibits influenza-like symptoms. Now, Dr. Koga has an elaborate exposure control plan that was developed in conjunction with our university health services, our infectious disease physicians, and our state, county, and city public health agencies. Now, this exposure control plan was approved by the CDC, NIH, and APHIS. All of our researchers receive seasonal influenza vaccines as well as have thermometers at home. All of the influenza strains used inside of the high containment laboratories are sensitive to antivirals. Researchers that qualified for a clinical trial have also received one of the H5N1 vaccines. And then in addition, there are personnel and avian quarantine policies, as well as an immunocompromised policy that researchers must follow. Now, for all of these risk mitigation measures to work and for them to work effectively, there needs to be a significant amount of communication. Dr. Koga and his researchers regularly communicate with our IBC and our Select Agent program. It allows all parties to be aware and to address any contingencies that may arise. Possibly the most important part of this decision-making process, this communication process, is that the decision-making process does not reside with the researchers or even with Dr. Koga. If anything out of the ordinary happens in one of the containment labs or with regards to the building, the researchers are obligated to notify the responsible official or the alternate responsible officials, and they, in conjunction with the Biosecurity Task Force, will determine whether or not there is a risk that needs to be addressed. Lastly, there have been questions about research transparency. The University of Wisconsin is an incredibly public institution. We have worked very hard to engage our local community and neighbors prior to building the Influenza Research Institute and during our annual maintenance window when the laboratory is decontaminated. We have been very clear from the beginning about the laboratory, its mission, and the research conducted there. Once more, we have a documented history of providing tours and briefings for select individuals, including local and campus officials, first responders, journalists, state legislators, and congressional staff. A case can be made that our Influenza Research Institute is one of our most public research settings. Thank you.
Thank you very much. And our last speaker for the panel will be Marc Lipschitz.
Thank you for the opportunity to speak here. The views expressed in this talk are mine and not necessarily those of the NIH or my institution. The calculations I will present are similar to those of Klotz and Sylvester and are provided in a new article by Tom Inglesby and myself recently published in MBio. I will focus on biosafety, not biosecurity. I will focus also on novel influenza gain of transmissibility experiments, not coronaviruses and not gain of pathogenicity. Although I think formal analyses are needed in those areas, my guess at this time, reinforced by what we heard in the last session, is that the risks of mouse adapting coronaviruses will be smaller and the benefits greater than those of flu gain of transmission experiments. In mortality terms, modern laboratories overall have a rather encouraging safety record, as Mark Dennison said in one of the question periods. Over 26 years up to 2005, about 24 people died of laboratory-acquired infections. Yet there have been some major breaches in BSL-3 or higher containment. The 2007 Pirbright accident with foot and mouth disease caused months of major economic losses for British agriculture. In 2004 in Beijing, as you heard, there was an outbreak of 9 cases of SARS, and it is thought that the 1977 reemergence of H1N1 flu resulted from a laboratory accident. Incidents like those at CDC and NIH last summer highlighted the need for better safety and oversight and the inevitability of human error, even in the best labs, which can overcome the most sophisticated mechanical systems. But taking the long view, pathogen research has been a rather safe endeavor. If we consider that laboratory safety is essentially a problem of occupational health, this record is quite reassuring. For the vast majority of research on dangerous pathogens, this is the right perspective. Most dangerous pathogens under study are already out there in nature, such that having them in a lab does not contribute materially to the global burden, and they are either poorly transmissible and in many cases can be, controlled by vaccination, natural immunity, and effective treatment. They present individual risk to laboratory personnel, but not to the general public. For this large majority of pathogen research, including over 200 current NIAID flu projects, we decide on scientific questions, choose an approach, and then find a way to mitigate risk through biosafety, and that's as it should be. Oops. A very small subset of experiments falls into a different category because we recognize that biosafety concerns are not limited to the occupational health of individuals in the lab, but are global public health concerns because of the risk of transmission. This includes experiments with smallpox, which are tightly regulated and prohibited unless approved by an international committee, as well as about a dozen influenza projects included in the current funding pause. Because the magnitude of potential harm is much greater for these few experiments, we may not be willing to accept a rate of accidents that we do accept when the risk is limited to individuals. Thus, for the very small fraction of influenza research that presents a public health risk, it should be subject to greater scrutiny, seeking lower risk alternatives and perhaps insisting on them. The deliberative process now underway recognizes this shift towards a public health view of biosafety in certain instances. Let me try to quantify this. Here I'm doing a very elementary and preliminary way, what the risk assessors will be doing with much more detail in the coming months. Laboratory-associated infections in BSL-3 labs using select agents in the U.S. happen at a rate of about 2 per 1,000 laboratory years, or 2.2% per lab year. In the NIAID intramural BSL-3 labs, another way to look at it is about 1 accident for every 100 full-time person years working in a BSL-3 lab. That's higher than the number that we just heard from Dr. Wyatt, I think because it's for full-time worker years rather than worker years. In public health, as in other fields, we quantify risk as probability times consequence, creating an expected value of the risk. Here, the pandemic aspect of the risk is quantified as the probability that a pandemic occurs from each unit of experimentation times the impact of a pandemic. We can split up the probability into the probability of a lab-acquired infection per unit of research times the probability that a single lab-acquired infection leads to a pandemic. The first figure, as we have seen, is at least 0.2% per laboratory year in BSL-3. The second figure, based on a number of models, ranging from very simple branching process models to an elaborate simulation designed for this question and incorporating many safeguards assumed to be in place, is between 5% and 60%. Oops. When we multiply these numbers, we arrive at a probability between about 1 in 1,000 and 1 in 10,000 per laboratory year working on a transmissible novel influenza virus that a pandemic will arise through a lab accident. A more detailed analysis would adjust these probabilities to account for such factors as control measures that might be in place if the infection were recognized beyond those already accounted for by Merler et al. In their study. Also for the use of vaccines and prophylaxis in lab workers, and for the additional features of BSL-3+ compared to BSL-3. On the other hand, the figures derived from the literature are minimum estimates, and lab safety varies dramatically and might be not as good in all labs where such work happens as in the ones where it is happening now. On the consequence side, we multiply the likely attack rate of a pandemic times the case fatality risk times the global population. The previous 4 pandemics have had an estimated attack rate of 24% to 38% of the population. That is the number infected during the pandemic year. The case fatality risk is hard to predict until we see the strains. Wild-type H5N1 has a case fatality risk of nearly 60%, according to some leading virologists and epidemiologists. Some have disputed this figure and claimed that it is too large. For other strains, the CFR will be different. To reflect this uncertainty, let us consider a range of CFR from 1% to 60%. When we multiply through by the world population, we estimate that a pandemic with a CFR between 1% and 60% would cause 20 million to 1.4 billion fatalities. Recall that 1918 flu had a CFR around 2%, and that in the pre-pandemic planning that was done in the mid-2000s, any CFR above 1% was considered to be the highest level of severity. These consequence estimates, too, could be adjusted. You might think that the CFR could go lower than 1%, though I would argue that one could not be sure of this when we initiate an experiment. On the other hand, the mortality estimate excludes social, economic costs, plus the exceptional damage that would occur to scientific credibility were there a human-generated pandemic. When we combine these provisional numbers, we lend some substance to my claim that these experiments create a public health risk. Using the low end, these experiments, in expectation, create 2,000 deaths per laboratory year. On the upper end, the number is 1.6 million per laboratory year. It bears repeating, of course, that these numbers represent a very small probability of a very severe outcome. By far the most likely outcome, of course, is no pandemic at any given lab year of work. The problem is that risk accumulates and should not be ignored when the consequences of an accident are on this scale. How should we quantify the benefits, which will eventually be compared against these rather dramatic risks? As any economist or decision scientist will tell you, and as we've heard several times today, it is not informative to ask the question of what are the benefits of doing these experiments in a vacuum. The reason goes back to the idea I and others have spoken about before, opportunity cost. When we fund one science proposal, given a fixed and tight budget, that means not funding another proposal. Therefore, to account for opportunity cost, we must weigh the benefits of enhancing ferret transmissibility of flu against other ways to study and defeat the flu, which is, after all, our shared overriding objective. What are these alternatives? And Dr. Kawaoka kindly showed a table like this from one of our earlier publications, one of my earlier publications. A few are on this slide. Without going through the details, let me make a few points. First, the high cost of ferret experiments and biocontainment means that ferret transmission enhancement studies will only be practical in very limited numbers of strains, even if this work is considerably increased. The papers published to date have used as few as 2 ferret pairs in some experiments, raising major questions about the statistical validity of their conclusions. Alternative approaches in vitro or using sequence analysis can be much less expensive, higher throughput, and therefore more informative about the great variety of strains out there in nature, even if they are unable to answer precisely the same questions, but rather address slightly different questions. Money not spent on ferret transmission gain-of-function studies could also be used in other promising approaches to improve our preparedness for pandemic flu, including work on universal vaccines, creation of more diverse seed stocks for vaccines, acceleration of vaccine production, and enhancing surveillance. Knowing the mutations that confer transmission in ferrets is not the only way and may not be the best way to defeat the flu. So the way to think of it is that we have a portfolio of approaches to flu research and countermeasures, including the ferret transmission enhancing experiments, which I have abbreviated using Lynn Klotz's term PPP, or potential pandemic pathogens, as well as other studies in flu virology and other approaches that focus on vaccine development or enhancing surveillance. We should weigh the benefits of this portfolio, symbolized as a cube here, against those of a portfolio that commits the same human and financial resources to more of the alternative virologic approaches, more of the surveillance and vaccine work rather than potential pandemic pathogens. This is how you account for opportunity cost. But we also have to weigh the risks, and I would suggest that the risks of PPP experiments weigh strongly in favor of the alternative portfolio because, as I have noted, they are very large, by comparison with alternatives which create essentially no pandemic risk and therefore no appreciable risk to public health. I believe that we could debate whether PPP work is more beneficial than devoting the same resources to expanding surveillance, making more vaccine seed stocks than the alternatives. I doubt it, but the key point is that if the dozen gain-of-function projects don't get done, those same top-notch investigators will do other good science that promises predictable and unpredictable benefits. In any event, once the risks are taken into account, I believe this small class of experiments, gain of mammalian transmissibility in pathogenic flu with novel strains, cannot be justified relative to alternatives. You should scrutinize every number I have used, but please remember that the lower bound of my estimate is 2,000 deaths per year. If you think that that lower bound is too high by a factor of 3 or 10 or even more, please make the case. But even the new lower bound will contain some alarming numbers. With an expected death toll, if we reduced it by a factor of 10, if we would still be talking about an expected death toll from 1 year of research comparable to that produced in 26 years of research, the 24 deaths I mentioned earlier. I hope that the risk-benefit analysis over the coming year will be an independent, disinterested, and credible look at these sorts of considerations for risk and an appropriate weighing of opportunity costs and benefits with respect to the benefits. I have recently founded with a colleague the Society for Safe Science, which will be monitoring this process and providing opportunities for the wider public to join this important public health discussion. Thank you.
Thank you very much. I'd like to invite people to come to the microphones if they'd like to ask questions. And while people are doing that, I'll just take one that came in on the web. First, by way of a comment simply, was from a listener in White Plains, New York. First, the comment, he made the point that he thought that even though this is indeed a global issue, that this committee and the NSABB should focus on those things the U.S. government can do, because those are the only people that we can actually influence directly. But his question was really one that kind of shades from biosafety to biosecurity, and that was how one can assess not the kind of external threats from things like bioterrorists, but the insider threats from, for example, a disgruntled worker or anybody else like that in the laboratories. Is this something that needs to be put into the risk assessment, he asks?
I'll be happy to take the first whack at this. With respect to our work in select agent regulatory area, we consider the insider threat to be extremely significant, and if one looks at the regulations, especially the modifications that we put in place in 2012, where we identified a subset of the select agent list that includes those agents of highest risk, the Tier 1 agents, many of which are included in the federal DIRT policies. Institutions that possess those agents are required by regulation to have a personal reliability program in-house. That program needs to have two basic pieces. One is a pre-access vetting piece that's done at the local level, and the second is a post-access monitoring piece. So with respect to select agent biosecurity, we consider the insider threat to be significant and merit attention.
Start on this side.
Thank you. I'm Jim Welch. I'm with the Elizabeth R. Griffin Foundation. Also serve on the board of the International Federation of Biosafety Associations, where I'm the global envoy for biosafety. I want to make an affirmation of one of Dr. Johnson's comments, if I may, particularly in regards to reporting laboratory-acquired infections and the need to develop a repository for that information beyond simply select agents and those that are referred. Many of you may be familiar with our organization and the fact that we partner with Eagleson Institute to do the Occupational Medicine Colloquium for Biological Exposures each year. We serve an audience of the research institutions, many of whom are present here, and also the public health sectors from many of those communities. And it's important to note that oftentimes it's rather spooky that, first of all, they don't know what's happening in the laboratories in the institutions that they serve. But secondly, they almost all, without exception, have anecdotal reports of laboratory-acquired infections that show up in their offices. And whether or not they show up on the statistics, I do not know. But the research community could certainly gain from the lessons learned. I also want to comment, if I may, Dr. Lipschitz, your comment regarding public health. I want to really emphasize this in under-resourced areas where public health is the occupational health provider. In areas where health capacity, particularly on the delivery, is extremely stretched by diseases and conditions that are endemic, they have no space for something else to hit them. And so incorporating the public health agencies in those areas is of vital importance. Thank you.
Thank you. Anybody here would like to respond at all? Okay, then, Michael.
Mike Imperiale, Michigan. I have two questions, if I may. The first kind of follows up on that. It's a question for Dr. Johnson. You said, and I'm paraphrasing here, that it's not uncommon for institutional leadership to not report incidents, and I'd like to know what the evidence for that is besides anything anecdotal. And then my second question is for Mark and Rob. You guys came up with very different estimates of the infection rates, and Mark, you said maybe this is a full-time, part-time thing, but you're off by like at least 2 orders of magnitude, so it's hard for me to believe that it's just differences in whether someone's a full-time worker or a part-time worker. So I was hoping you could each comment on that.
Sure. The evidence is, of course, what you could call anecdotal because it's not in the literature. But what it comes down to is when we go to accredit or to certify a laboratory, they will ultimately say, oh, and we had this laboratory-acquired illness, or we had this exposure with the following illness. And then when you say, okay, so does the institute writ large have this information, and is this going to be reported publicly? The answer is no, we're not. The second thing is you go to some conferences, and when you discuss, we want to make this global move where we can start reporting things without putting people's names to it, without disparaging the reputation of an institute, but we just want to know what happened, why do we think it happened, how can we prevent it. We have many very, very senior leaders in other countries who say, that's the worst idea I've ever heard of, we would never participate in that because no good is going to come of it, it'll shut down my facility. And this happens in more countries than you can imagine, unfortunately.
Thank you.
Yeah, with respect to differences in the numbers, I mean, Dr. Lipschitz and I probably need to compare notes in terms of how we did our calculations, but I think the bottom line is that no matter how you calculate it, with 5 confirmed laboratory-acquired infections in a sector that involves around 300 or so institutions, 10,000 individuals over a period of 7 years, that rate is going to be quite low.
Yeah,
it's just that I think the number that Mark gave is not quite low. I guess that's what I'm trying to get at here.
So the numbers that I carried through the entire calculation from reasons of time were not the ones that are different from him. They were the ones that were taken from his earlier publication, which was 0.2% per laboratory per year. The one that was on almost the same scale that did disagree, in my case, was came from NIAID, which reported to Homeland Security in a publication that I cited on the slide, that there had been 634,000 laboratory worker hours in which there were 3 infections. So 634,000 laboratory worker hours is 317 laboratory worker years if a person works 2,000 years full-time. Of course, nobody's in BSL 3 2,000 years. So you would 2,000 hours a year, 2,000 hours a year. So you would adjust it based on that, and so we're off by a factor of 20, and so if someone spends 5% of their time in BSL 3, that would completely reconcile them.
Chuck Haas, Drexel University. Underreporting interests me as well, and I wonder if there's either any serious way to estimate what underreporting rate might be, or perhaps take advantage of other regulated industries and look at what they know for underreporting to use at least as a bounds in getting at that value.
I guess I'll take a whack at that. You know, we've been in this regulatory business now for about a decade or so, which compared to other regulatory programs isn't a long time. I suspect that one could look at rates of naturally occurring infections associated with select agents in the United States and begin to make a comparison or an investigation of naturally occurring cases where they've occurred, if there's any association with those, and work at a regulated entity. That might be a place to start.
I'd like to go just take that one thread further. So the underreporting that, the number I came out with about 20% of known incidents is based on Sulkin and Pike and some of the earlier work where people that became ill and it was determined it was laboratory acquired, in only 20% of the cases did they recall what went wrong. So in 80% of the cases, no one knew what this was attributable to. I think we've gotten a lot better. We know not to eat and drink in the lab. Okay, so that's a good start. But I don't know how we account for all these other incidents, improper doffing of PPE, and then insufficient hand hygiene. Okay, these are all things that are realistic that we know from Texas happen. That's healthcare, that's not the lab. But the other thread that I wanted to pull on this was we're talking about reporting of known illnesses. I don't know how we'd go about even reporting seroconversions that were an indicator of an exposure, but you didn't have signs or symptoms, and that's even further off the edge of, I think, Chuck, what you brought up. But that's got to be part of it, and I don't know how this type of industry can look at that.
And I would just very briefly add that, of course, the better the medical response to potential exposures, the more of that kind of underreporting there will be. Because if someone's infected and is promptly and effectively treated, they will probably not be detected as an infection.
Yeah, if I might add to that, pull that string out a little further. One of the things we believe that's been one of the most effective results of the select agent regulations is that regulated entities must have an incident response plan. They must have thought through how one would respond to a potential exposure for a laboratory worker. And I think, as Dr. Moritz described the program at Wisconsin, you know, every registered entity that's working with these agents has to have a similar plan. They have to know who to call when they get that call at 4 or 5 or 6 or 7 on a Friday night where someone's in an emergency room with a fever. If the response can be done quickly enough, if a countermeasure can be applied quickly enough, one could prevent someone from getting sick.
I will second the fact that if you are part of a select agent program, the option of noncompliance doesn't exist because you will be shut down, and the CDC and APHIS have shut down other select agent laboratories. So if you would get a lab-acquired infection or you would have a potential exposure, you do not have the option to not inform the CDC or APHIS of that.
Before we take the next question from the audience on that side, since you've mention that, I want to bring one in from the web, from a faculty member at Johns Hopkins, and he writes, specifically to Rebecca Moritz, "You've convinced us that you have reviewed the research in Wisconsin repeatedly and followed all the rules, but all the parties involved in the review seem to be at Wisconsin," which he says naturally would want to approve the experiments done by its own scientists. So he asks, have you ever rejected an experiment that you reviewed? And he's not asking if you requested improvements or changes, but actually told somebody no.
I think that is a very good question. To the best of my knowledge, in regards to some of the research of gain of function or things like that, we have not said no, but that's not because we feel that the risk mitigation measures in place are appropriate. And mind you, this type of oversight, select agent research, export control, dual use research of concern, is not a money-making research endeavor. It costs a significant amount of money for the university to be able to oversee such research. So we're not going to say yes to something that is going to potentially jeopardize our $1 billion research enterprise.
Yes.
Yes, Mark Dennison. I have a comment and then a question for three people. I'll give them all and you can memorize them. Is my mic on? Is this on? Okay. My general comment is that it seems like all of the comments here really had more to do with containment, reporting, occupational health, and mechanisms for responding and being sure that we're getting full information than they did with gain-of-function research itself. And I think that's relevant and important because I think a lot of the issues go to really exactly how we use the terminology and what we're talking about. And particularly if we can restrict our denominator to those things that are current, relevant to our current laboratories and our current research programs that are going on in the areas under consideration, I wonder if it would change the thing. So I have a couple of questions. One for Dr. Johnson. I guess I was a little disturbed by the implication of hidden or under-reporting because we work so hard at it, and I thought you may have clarified that. If you could clarify that, is that in this country? Because for those that I work with in these institutions, we're all working under similar conditions, as Dr. Moritz said, and so the opportunity for under or non-reporting is not there. At Vanderbilt, we've also put in place mechanisms for alternate reporting because our primary concern is with the safety of those working on the pathogens and with the public. And so up all the way through the dean and the chancellor's office, we have alternate reporting strategies for those working in the laboratories to be sure that there's no potential incident that's non-reported. So I guess that was my question for you. For Dr. Wyatt, the terminology I think is sometimes problematic is the issue of potential exposure. That is, when we have primary, secondary, and tertiary containment, if I have a spill on the floor of my laboratory and someone is in appropriate PPE and clears it up, I believe that would be called a potential exposure, but it's not an exposure, and it's not a laboratory-associated infection. So I understand the issue of why it's called that, but I guess I'd help to clarify it in terms of true risk. That is, in people who are working appropriately and have an event or something that occurs in the laboratory that is appropriately responded to based on the standard operating procedures and methodologies. And for Dr. Lipschitz, the issue for, I guess your thing to me just felt like, I guess I don't really have a question. It seemed to me that it was more of an argument for strengthening public health responses and being sure that we don't have underreporting or opportunities for release of a pathogen. So, if any of you have any responses to any of that.
Thank you. I think you might have misunderstood the context. The underreporting and the non-reporting is more prevalent in a number of emerging and developing countries that I'm in. And this has come out on some UN panels that I've worked on, as well as a Ministry of Health certifier and an advisor to a number of different facilities and entities. I don't imply in any way that this is active in the U.S. In terms of underreporting, if you want me to go on in the U.S., the underreporting is, yes, it goes to the appropriate authorities. It goes to the CDC, USDA, Federal Select Agent Program. It goes through the NIH to the RAC, which all this is appropriate. But a lot of times we don't see an MMWR case study.
I guess my
that-
question was, is that related to flu and coronaviruses, or does this include diagnostic laboratories that aren't, that wouldn't be captured under the current discussion?
I'd love to see any LAIs discussed in an open, public manner and published so that we can learn from it, because if you're in a diagnostic lab and you've got an LAI, wouldn't you, as the head of the Public Health Service, wouldn't you want to know what to do to fix that problem?
I certainly would. I certainly would.
And the same goes with a research lab. So I'm not criticizing our reporting here. I just want to see more.
I think with respect to your question about scenarios of exposure, I think the best answer I can give you is it depends. Each incident is unique, and what we do is we encourage responsible officials at registered select agent entities to report everything to us, and we work with your safety folks and with your principal investigators to determine really what is the true probability of someone having been exposed. You know, that scenario that you just mentioned to me, my first question would be back to you is, did this spill occur within a biological safety cabinet, or did it go down to the floor? If it went down to the floor, it breached primary containment, there may be other issues. So it's not as simple as it might seem. And I think our current guidance document there has probably close to 20 sort of sample scenarios, and just when we think we've got them all covered, someone will call us with something new.
Thank you.
Marc Lipsitch?
Thanks. With respect to the comment that we should be using the record with gain-of-function labs and not others, if we had enough data from gain-of-function labs, we could do that. I would say, just guessing, there have probably been well under 50, certainly well under 100 laboratory years of experience with gain-of-function of this narrow category that I just defined. If there are only two possibilities, really 0 or 1, because it would have been stopped if there was 1. But the numbers I'm giving say that the by far most likely answer is that in the amount of time we've been experiencing transmission enhancement of highly pathogenic novel flu viruses, the only really likely outcome is 0 events at this stage. In terms of strengthening public health, of course, I'm all for that. I just think that we need to, that the best thing we can do to strengthen public health when there are certain tiny class of experiments that directly threaten public health is to find alternatives.
I must note that we've only got about 8 minutes left, and we have 4 people at the microphone. So, with your permission, I'd like to just ask all 4 people to please make their comment or ask their question, and then I'll have the panelists run down the line and respond to them all at once, and maybe that way everybody gets a chance to participate. My apologies for the time constraint. Why don't we start over here?
Great. Tom Inglesby from the University of Pittsburgh Medical Center. I had 2 questions, if you get to them. If not, the first was for Rebecca. Some scientists and some institutions have said that they don't feel that they have all the expertise necessary to manage all the DIRC, GOF, biosafety issues engendered by these experiments. What's your experience been at University of Wisconsin? Have you had troubles answering all of the complexities, especially since there are larger implications beyond the university? And the second, related to that, for anyone on the panel, maybe for Rob and Rebecca, is if something does go wrong with this research, and it's highly transmissible, highly virulent research, and it causes community spread, who should be accountable for that? It's quite different from other scenarios where people are injured within an institution. What's the mechanism of accountability for that? Is it that institution? Is it something larger?
Take notes. Yes?
Yeah, I basically wanted to reinforce Barbara's point about underreporting with some additional anecdata. Internationally, at least. 2 weeks ago, I was at an international meeting where we, among other things, tried to agree on some really modest language about this. Agreed on the value of, consistent with national laws and regulations, improving data collection on laboratory-acquired infections and potential releases for the purposes of better risk assessment, et cetera. That's kind of innocuous, I would have thought. Doesn't commit anybody to doing anything, says that if you're going to do anything, it should be consistent with whatever laws and regulations you've already got in place. It ran into a buzzsaw. absolute adamant opposition from a number of developing countries, no meaningful support from the EU or any developed country to speak of, just no interest in addressing that, when both from the standpoint of data for assessing risks like this, but also from the standpoint of trying to improve biosafety and biosecurity practices by looking at what we're doing now, finding the problems and addressing them, zero appetite. I find that a little bit troubling, and it seems to me that this really is an important piece of data for a lot of the things that we want to do.
Thank you.
Kanta Subarao, NIH. So I just wanted to reiterate something that I'd said this morning that Mark Dennison was getting at just now. With regard to the numbers being pertinent to the types of research we're talking about today, SARS, MERS, and influenza, all influenza. And I think, Mark, you just said that the number of lab years of data that we would have is very limited. But we've really been using BSL-3 labs with PAPRs since 1997, and there have been no reports of laboratory-acquired infections during that period. We have a lot of medical support and surveillance for all the lab workers, and the availability of vaccines more recently. So my plea would be to try to incorporate those sorts of discussions into the calculations and see how they alter the calculations from the sort of runaway numbers when there's no intervention at all.
Thank you.
You said BSL-3 labs with what?
PAPRs.
So if I can just ask the panelists to kind of go down the row and take a minute or two to respond to the comments or the questions.
I want to start with the other end because I don't really have one.
All right, well, we'll start with the other end. Marc Lipsitch.
I think as a general matter, I think we should incorporate all the data that's available, and the more relevant, the better, and there will be some weighting scheme. I think that the data from the NIAID, the data I presented from the NIAID intramural labs was 317 BSL-3 worker years, in which there were 3 laboratory-acquired infections. I'm not sure how that compares to what you were just describing or exactly what period of time it was. It was a 2007 report, but we can settle that afterwards. But I agree. I mean, if these numbers are too high, we should find better ones.
Yeah, those numbers ended in 2003, and there was no active program to work on flu until after 2003.
To answer the question about the amount of resources for select agents, dual use, and export control, as I said earlier, it takes a significant amount of time and man-hours to oversee this type of research. Fortunately for us, the University of Wisconsin has been very liberal in its resources that it has given us. In 2003, like I said, they gave us a dedicated select agent trainer, and that has been incredibly helpful, because previous to that, I was doing this job by myself. Hopefully we'll be able to get more resources in the coming years, but that is a very important point, that depending what comes out in regards to gain-of-function research, my guess is it would be, again, another unfunded mandate. And at some point in time, the scales are going to tip. And institutions such as ours are going to say, this just costs too much, we're not going to do this research anymore. And then where is public health going to be standing after that? And then in regards to the question about
accountability.
Accountability. So that is actually a discussion we have had. So we have all these risk mitigation measures in place. We have quarantine options available if someone would have an exposure or a potential exposure, or if someone would come down with influenza-like symptoms. Part of that personnel quarantine policy is if you would come down with symptoms and say you're at your house, your roommates, your friends, your family are aware of the fact that they will be quarantined as well. And occupational health insurance only covers to a certain extent, and then the insurance for the university would most likely have to kick in after that. But this is part of why we have engaged our state, county, and city public health agencies, so that they know exactly what's going on, what type of research that we're doing, and if the worst case scenario would happen, we have contingency plans in place to deal with those types of things.
Rob and Barbara, do you have any last comments?
Yeah, I just have a few with respect to Dr. Inglesby's question regarding accountability. The select agent regulations do have enforcement provisions, and when we get a report, one of the things that we do in our routine investigation is we try to determine whether or not there was any gross negligence or any nefarious activity and associated with an incident. We've had a few rare cases in which we've determined that to be the case, and we've referred those to the HHS Office of Inspector General. In the last decade, there have been around $2.5 million worth of civil money penalties levied against institutions that were found to be in gross negligence of the regulations. There's also a link with Title 19, the United States Criminal Code. If we have evidence that we think there may be criminal activity associated with that, we refer those cases to the FBI Weapons of Mass Destruction Directorate for additional criminal investigation as warranted. With respect to Dr. Sabaro's question, we've spent over the last, better part of an hour here, we've spent a lot of time telling you folks how few LAIs that are out there and how good everybody's doing in terms of safety. But I think with respect to gain of function experiments, however we define them at the end of the day, we really need to look at the consequence piece of the risk equation. We're talking about potentially the creation of agents that could be associated with significantly greater consequence than a garden variety pathogen or even a select agent. So that needs to be factored in.
So the final thing I wanted to say is this, whatever comes out of NSABB and this whole deliberate process, in theory is supposed to be something that can be carried to rest of world. And I'm here to tell you, rest of world, some of it's not ready. And so there's got to be some way to help pull rest of world up to an acceptable level, because we've seen it in Indonesia. They're not going to give you all their influenza, and they are going to want to do their own research. And every country is going to want to let their scientists do something, and it may turn out to be gain of function as well. And so we've got to be prepared to help and to feed them and to mentor them at a bare minimum and to strengthen this. Because you've all heard this little thing, the chain is only as strong as the weakest link. Whether the outbreak starts here, if there's an outbreak, or whether it starts somewhere else, we could be talking about super spreaders like SARS, or we could be talking about any other number of problems that are incurred by air transport. Because I'm here today, I'm in Singapore, Hong Kong, Thailand, Nepal, and Bangladesh tomorrow, right now. And that's my life. And that's how quickly these things do move.
I'd like to thank the panel, and we'll move on to biosecurity next. Thank you very much.